Okay, so let's continue with our topic, that is today is glomerulonephritis. That is glomerulonephritis. See, what is the glomerulonephritis? We know we have in when we talk about the kidney or the nephrons. So there we have the glomerular structure. See, we have this is what we have, the nephron type of structures, and the structures that present here, that is what glomerular structures. If there is any inflammations will be there, the nephron is what, kidney. If the glomerular kidney infections or the inflammations will be there, we call this condition as a glomerulonephritis. So when we talk about the glomerulonephritis, we talk that there in glomerulonephritis, we talk the hallmark is what, that is what we will see. We will see the hematuria. What we will see? We will see the hematuria. Now this hematuria, it can be the less and it can be more hematuria. And gross findings, we will see the gross finding for all type of glomerulonephritis. We will see the cola colored urines. Gross findings, what we will see? We will see cola colored urines. What we will see? Cola colored urine will be seen. And when we are talking about the microscopic, see, if there is gross hematuria, what we will see? We will see the cola colored urine. But if we are seeing the microscopic findings, so what we will see? We will see there is a more than 5 RBC per house filled unit in centrifugal manner, in uncentrifugal. So when you are non-centrifuge, it's simply things like when we are just circulating all the materials, so that is what centrifugals. But if you are not circulating, that means it is simply what, uncentrifugal. So that is in uncentrifugals. And if it is more than 10 RBC per house filled unit in the centrifugal, okay, you need to just remember, if there is a more than 5 or more than 10 is something there, then you need to check the just, is it centrifugal? Centrifugal, there will be the more RBC we needed. But भाई पेपर तो आ तो जाने दो यार, पेपर लीक तो बाद में करवाने, अभी पेपर लीक ही चल रहा है. दिस क्वेश्चंस विल कम, दिस ऑल इसी में से तो आएगा, और कहां से आएगा? तो अभी तो पेपर बहुत टाइम है ना, अभी तो जस्ट रिलैक्स रहो, अभी पहले पढ़ लो. वो एक देयर इज वन गाय लेडी गर्ल इज देयर ना, पढ़ लो, पहले पढ़ लो, ठीक है? तो पहले फर्स्ट स्टडी, then gross where the cola colored urine microscopically there is a more than 5 RBC per household and centrifugal manners, and more than 10 RBC per household unit in the centrifugal manner. That is what, that is glomerulonephritis. See, what will be what other characteristics we will see? What other characteristics we will see in these conditions? So we will having the RBC cast, the characteristics, other characteristics findings. We just studied if we have the if we will having the pyelonephritis. In pyelonephritis, what we will see? In pyelonephritis, we see there is a something WBC cast. But in glomerulonephritis, we see there is a RBC cast. But in the glomerulonephritis, what we will see? We see there is a RBC cast will be in the urine. So that is what characteristics findings, and what we will see, the RBC cast in the urines. Other things we will see, there is a dysmorphic RBC. There will see the dysmorphic RBC. What does it mean by dysmorphic RBC? So RBC having the abnormal shape. So these are the dysmorphic RBC, and that will be more than 20%. The dysmorphic RBC, that is more than 20%. Other than that, we can having the mild proteinuria. See, we will study all these glomerulonephritis, nephrotic, RPGN, PSGNs, everything we will study in every conditions. What we will see the proteinuria. And remember guys, that if we have the massive proteinuria we will see in this condition of nephrotic syndromes. Massive proteinuria we will see in condition of nephrotic syndromes. We will see in the condition of nephrotic syndrome. So we will having the mild proteinuria and we have the massive proteinuria, in which we see the nephrotic massive proteinuria we will see in case of nephrotic syndromes. Okay, then after that, remember, we can having the pedal edema, we can having the pedal edema, and we will having the periorbital edema, the pedal edema, and we can having the periorbital edema. See, periorbital, I just told you in one disease. Which disease was there? In rheumatology base we studied that periorbital edema is seen. Which disease? Periorbital edema is seen in between I will keep asking, so just let answer me the periorbital edema. Now I will tell the name of the rash and you will say, oh, this. अच्छा, ये वाला था. So what was the heliotrope rash seen in which conditions? Heliotropic rash. The heliotropic rash seen in which conditions? I think you are not able to hear me, na? यार किसी से शर्म आ रही है तुम्हें? Hello, heliotropic rash seen in dermatomyositis. The dermatomyositis. Okay, one leak question from Croc 2. One leak question. It is seen in dermatomyositis, periorbital edema, heliotropic rash. I send the image also. See, heliotropic rash, this is the leak question from the Croc 2. So remember, heliotropic rash seen in dermatomyositis. है ना? Pedal and periorbital edema. The pedal and the periorbital edema. So remember these things. The characteristics finding. Now let's talk about different like we have the type of the glomerulonephritis. Then we have the nephrotic as well as we have the nephritic syndromes. Nephrotic as well as we have the nephritic syndromes. See what happened in the nephrotic syndromes. What happened in the nephrotic syndromes? Nephrotic syndrome, remember, if we are getting the massive proteinuria, see, whenever the nephrotic syndromes comes, so think of, oh my god, something like that. That should be the reaction, oh my god, like reactions will be there. See, there will be the massive proteinuria, there will be the lipiduria, and the major protein from our blood that will be reduced. Oh my god, that is hypoalbuminemia. Then we will having the patients will having the edema. As I just told you, there can be the pedal edema, there can be the periorbital edema. Other than that, we have the can see there is a thrombotic event will be there. And what the thrombotic event we will be having? We will see there is a antithrombin 3 in urine. The antithrombin 3 will be seen in urine. So that is prevent the clots. That prevents what? That prevent the clots. Okay. The massive proteinuria, lipiduria, hypoalbuminemia, edema, thrombotic event, antithrombin 3. Which is the thrombotic event? Antithrombin 3 we will see in the urine, and this will prevent the clot. So that is what nephrotic syndrome. What is the nephritic syndrome? See, in nephritic syndrome, as I told you, in glomerulonephritis, in the most of the cases we will see mild proteinuria. This is again the leak questions. So remember this one as well. Nephrotic, nephritic, important leak question for all exams. So in every exam, this question is super important. So nephritic syndrome, remember this is the mild proteinuria. The mild proteinuria. So in the mild proteinuria, we have the less than like 1 gram per 24 hour in urine. This you need to remember. Also remember the value of nephrotic syndrome or the proteinuria as well. More than 3.5 gram per 24 hours. More than 3.5 gram per 24 hours in urine. That is what massive proteinuria or the nephritic syndromes. In the nephritic syndrome, what we will see? We will see the mild proteinuria. We will see the mild proteinuria. So what we will do in the nephritic? We will do hoo ha, hoo ha. So what is that? Hoo ha, hoo ha, hoo ha. Okay. So that is what hypertension. What we will see? We will see there is a hypertension. Then what we will see? We see the oliguria. We see the oliguria. H4 we see there is a hematuria. See, hematuria will be also seen in nephrotic conditions, but that is very less. So that we no need to remember. So if in the questions like Croc 2 questions, hematuria comes directly, so that means he is talking about the nephritic syndromes. And hematuria, I told you that there is a gross finding is there. So cola colored urine, that is cola colored urine. So what we will see? We will see there is a cola colored urine will be there, the cola colored urine. Along with that we have the azotemia. There will be the azotemia. What is the azotemia? There is an increase in blood urea nitrogens. In azotemia, what will be there? There is an increase in blood urea nitrogens. Now the important thing about the nephrotic or nephritic syndromes, another important thing, that is their example. So remember the example of the nephrotic and nephritic syndromes. So what are the examples? We will having the MCD, that is minimal change disease. What is that? Minimal change disease, that is minimal change disease. Then we will having the FSGN. I'm just writing the short forms. We will write it further. Then we will having the membranoglomerulonephritis and we will having the membranoproliferative glomerulonephritis. What is the example? We have the minimal change disease, we have the focal segmental glomerulonephritis, we will having the membranous glomerulonephritis, membranoproliferative glomerulonephritis. Then another example we have, that is the post-nephritic example we have post-streptococcal glomerulonephritis. We have the Buerger's disease. Buerger's disease, yes, today I ask you what is that? IgA nephropathy. And also we will have the RPGN, RPGN retrograde polyglomerulonephritis. So this you need to remember. Just remember it, revise it for again. Speak with me. Minimal change disease, FSGN. So all the M findings, all the MY, all the MM. So NM. So nephrotic are the M1. So minimal change disease, minimum glomerulonephritis and the membranous proliferative glomerulonephritis or the focal segmental glomerulonephritis, that is what? Nephrotic syndromes. Then if we are seeing the PBR is what? P4, PSGN, Buerger's disease, and we have the RPGN. So these are the nephritic syndromes. What are these? These are the nephritic syndromes. I hope this is clear. Now let's continue with that and continue with the same things. So we will having the post-streptococcal. We are continuing with the nephritic first. See, PSGN. Okay, PSGN is post-streptococcal glomerulonephritis. This is the most commonly associated glomerulonephritis. The most commonly associated glomerulonephritis is what? Or the most common finding that we see is the post-streptococcal glomerulonephritis. So what happened in the post-streptococcal glomerulonephritis? See, if we will having the streptococcal infections, so there the streptococcus I told that cause the pharyngitis. That cause what? Pharyngitis. And when this pharyngitis will be there or any skin infections will be there, like examples pyoderma or impetigo. The another questions of the Croc 2, the impetigo, what we will see? Honey crust appearance. In impetigo, remember this is again the question, leak questions, note it down, that is honey crust appearance. The honey crust appearance. So honey crust appearance, we have the impetigo. And the impetigo, what it is also caused by the streptococcus. So the two questions, impetigo it is caused by the streptococcus. Then it is a honey crust appearance. It's seen in case of the impetigo. You will get the characteristics finding or the characteristic keyword in the questions, honey crust appearance. That means he's talking about impetigo, or maybe they ask you the organisms causing that is streptococcal glomerulonephritis. So the pyoderma, that is also caused by the streptococcus. So whenever these infections will be there, so after few periods, that this period, we call this period as the lag period. After the few periods, they can affect the kidney, and after that it will convert into the glomerulonephritis. Okay. So what happened in the lag period? In the lag period, there is a streptococcal antigens. There is a streptococcal antigen. There is a streptococcal antigen and anti-streptococcal antibody. There is anti-streptococcal antibody. So what are they making? Antigen or antibody, the complex that makes what? That makes the immune complex. That makes what? Immune complex. Now this immune complex will deposit in the kidney. Now this immune complex will deposit in kidney, and what they will cause? The immune complex will deposit in kidney and it will cause the glomerulonephritis. I hope this is clear. So pharyngitis, pyoderma, any streptococcal infection, so there will be some infection will be there, and after the infection there will be, after few period, it will convert into the glomerulonephritis, and that is what, that is known as the lag period. In the lag period, what will be there? Antigen and antibody will be like complex will be formed, that is immune complex, and they deposit in kidney. Can you tell me this is which type of hypersensitivity? This is which type of hypersensitivity? That is immune complex deposition, like same like SLE. So this is again the type 3 hypersensitivity. This is type 3. Will very good, Pragyana. This is very good. Hypertension, hypersensitivity 3, type 3 hypersensitivity. Okay, HYS. Now what happens? This immune complex will deposit in the kidney and they causing the glomerulonephritis. Now, in what other things we can see in case of the PSGNs? In the PSGN, if you see, there is a gross findings. The gross findings we will see, that is a flea-bitten kidney. What we will see? Flea-bitten kidney. Now, they will not give you the image, but you can find this type of the keyword in the question. So you need to remember, if there is a flea-bitten kidney or the pinpoint hemorrhage. I am writing all these things here so that I can share the images after the class. Okay, so the flea-bitten kidney you need to remember. So all these images I will send you after. So flea-bitten kidney, remember, there will be the pinpoint hemorrhage. So we will see in the kidney there is a pinpoint hemorrhage will be there, or pin hemorrhage means bleeding. The pinpoint bleeding will be there in case of the flea-bitten kidney. Microscopically, what we will see? Microscopically, this is microscopically. See, if I am little bit fast, just tell me or remind me that I'm going fast. Then in microscopically, we will having the starry sky appearance. Microscopy, we will having the starry sky appearance. So starry sky appearance, remember, that is seen in case of the immunofluorescence microscopy. The another immunofluorescence microscopy. What we will see? We see there is a starry sky appearance. What we will see? There is a starry sky appearance. And so what on electron microscopy, what we will see? We see there is a subepithelial humps. Subepithelial humps. See, I am not saying you, or we call this condition, okay, just write it down first. Podocyte deposits. Podocytes deposit. I am not saying you that you should remember everything from here, but you should, these things should be in your mind. There is something like that starry sky appearance, subepithelial humps. Maybe you will not able to, whenever I will say you immunofluorescence findings, you don't know what is that. You can say flea-bitten kidney, you can say the subepithelial humps. That is normal things that you need to find. So you are doing these first times. So in the first time you will be this, like if at the first time if you're getting that I know these things, I studied somewhere, so means that you are on the right tracks. So no need to worry about it. So electron microscopy finding, what we will see? Subepithelial hump or the deposits. Now the next one, the next disease we have Berger disease. The next second is the Berger's disease. Again, it is what? It is again nephritic syndromes. Again, it is what? Nephritic syndromes. See, the Berger's disease, this is also known as the Berger's disease. This is also known as IgA nephropathy. I hope you are clear till now that whenever I write AKA, this means also known as. Those who don't know, they also known as IgA nephropathy. This is also known as the IgA nephropathy. Berger's disease, that is the most common nephritic syndrome in adults. The most common nephritic syndrome in adults. Yesterday we talked about Berger's disease. I told in the Berger's disease, if you do the smoking and there is the cigarette, it is associated with the smoking, and we have the tau, also known as that is also known as the tau. Then I told in the Berger's disease, it affects the veins, it affects the artery, it affects the nerves, but it never involves the lymph. I hope this is just for your reminder that we already studied. Now we are talking about Berger's disease, and this is the nephritic syndrome, and which is the most common nephritic syndrome in adult and most common all over the world. The most common all over the world, that is Berger's disease. The most common finding we see, that is PSGNs, but in the Berger's disease, that most common all over the world, that is the Berger's disease. What is the cause of it? Again, group A beta hemolytic streptococcus. Okay, so what happened in this condition? In the same condition, what we will see the microscopically, there is again the IgA deposition in the mesangium. So there is a mesangium cell or the mesangial cells, there it will be deposited. What is the mesangiums? See, we have the glomerulus, and between the glomerulus we have some cell, and that is known as the mesangial cells. So this IgA will be deposited in the Berger's disease. That's why we called it as the IgA deposition. All these are what? IgA. In PSGN also we have the IgA depositions, but here also this is again the IgA nephropathy. So that's why we have the IgA depositions in the mesangium. The mechanism is what? Different for both of them, so that you need to understand. Okay, I hope this is clear till now. Now let's continue with another disorder, that is PSGNs. That is PSGN. That is no. What are the next diseases? Okay, PSGN GABHS. Whenever I speak, please see. This is again I am writing it RPGN. Yeah, I know. Group A. Okay, so we have this is the group A beta hemolytic streptococcus. Group A beta hemolytic streptococcus. Yes, we already did the PSGN. This is PSGN. This is PSGN. Post streptococcal glomerulonephritis. Post streptococcal glomerulonephritis. I hope this is clear. This is the most common, most common associations you will find, that is the post streptococcal, pharyngitis, pyoderma, impetigo. Lag period will be there. That will further lead to the GMN, immune complex deposition will be there. In the gross findings, we see there is a flea-bitten kidney, pinpoint. I think somewhere I told that IgA deposition in the PSGN as well. So here what is we have? I wrote it clearly, immune complex depositions. If there is immune complex deposition, that is in PSGN, and in the Berger's disease we have the IgA depositions, that is occur in the mesangium. Okay, the next is what we have the RPGNs, rapidly progressive glomerulonephritis. Okay, before the RPGNs, let me take a little time, that we have the PSGN. We studied about the PSGN and we studied about the Berger's disease. See, in the PSGN, we will getting the history of the sore throat. We will getting the history of the sore throat. See, bacteria is same. We have the group A beta hemolytic streptococcus. Group A beta hemolytic streptococcus. And again, there is a history of the sore throat. In both the organisms is same. So I told you there is a sore throat or pharyngitis will be there. So after it, PSGN, P4, PSGN, P4, pedia. So this is common in the children's. So in the common in the children's, and it takes 10 to 14 days. This is the lag period. The 10 to 14 days to convert into the glomerulonephritis, and maybe we can say that there is a hematuria will be there. After 10 to 14 days we see the hematuria or the cola colored urine. Then if we are seeing in the Berger disease I told that is common in the adults. That is common in the adults. And it just occur in the 3 days. So that is the very fast. So adult mein kya hai? Adult, they are the big in number. Adult, remember B, adult, the big. So they are the big in number. So it will become the jaldi. Okay, G4, remember the jaldi. Hai na? So it will become the fast. So in adult, it's 3 days we will get the hematuria and we will see the glomerulonephritis. Okay, this you need to understand this thing. Maybe in the question they will give you the age of the children's, or after that you will get that there is a patient is having after the 10 to 14 days this patient is having the hematuria conditions. And again in the case of the Berger's, they will give you if they will give you IgA deposition is there, history of the sore throat is there, and after 3 to 4 days the person's got the hematuria and the person having the cola colored. They will not give you hematuria, in between they will give you the person's having the cola colored urine. So what will be the findings? What will be the disease? So that is the Berger disease. Okay, the next nephritic syndrome is what we have, that is RPGN. That is rapidly, third one is rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. GMN is glomerulonephritis. Rapidly progressive glomerulonephritis. This is also known as, crescentric. This is also known as the crescentric glomerulonephritis. Why we called this as the crescentric glomerulonephritis? This kidney will become like the crescent. In this kidney will become like the crescent shape. So remember that's why we call this condition as the crescentric glomerulonephritis. What is the crescentric? It like half moon like shape, half moon shaped. It's called it's known as the like half moon shaped. Okay, if there is a crescentric or there is a increase in the number of the glomerulus or the glomerular structures, that will also become the crescent. And if the crescent glomerulus will increase in the number, it will become having the poor prognosis. So RPGN, this is also known as the crescentric glomerulonephritis, and also remember that it composed of fibrin, it composed of the leukocytes, means there will be the WBC amount will be increased in these conditions, and there will, what we will see, the parietal cells will be more. What is the parietal cell? What is the visceral cells? For now you can just understand if any organs or the visceral organs, they have the outer layer, that is the parietal layer, and inner layer we have the visceral layers. So this is, you can for now you can remember the parietal cells, that will be all the parietals on the outer sides, and the visceral layers, that is visceral cell or we can have the Bowman's capsules. So again you can have Bowman's capsule, we have the parietal and the visceral cells. So the parietal cells we will see that they are more than the visceral cells. Again these things they will not give you or they will not ask you directly, but yes, in the questions you will get this type of the like their fibrin something and parietal cell is there, so you will get the little idea or you can easily answer. That is what this is talking about, the RPGN. Okay, no need to worry, once we will finish everything, all the glomerulonephritis. I know this is a big topic, so that's why I'm starting from this. Parietal cells, the parietal cell of the Bowman's capsule. The parietal cell, these are the cells that present outside, and the visceral cells, these are the cells that presents or the like inside. Like for example, for our any visceral organs or any make acids in the stomach. Which one? Yeah, that is make acid in the stomach. That is the present in the that is one is different. That one is different. Okay, that is like for the GIT part. Here we are talking about the kidney part. Okay, the parietal cells, no, it's no problem that we can see in the GIT as well as we can see this condition in the kidney as well. Okay, so these are different things. Also, what we will see there is a wrinkling of the basement membranes. Wrinkling of basement membrane will be there. If you don't know what is the basement membrane and this, just before remember there is a basement membranes that present glomerulus. We have the below the glomerulus we have the basement membranes, and the basement membrane, so there will be the wrinkling or the atrophy of the basement membrane. This will be also seen in case of the RPGN. Now RPGN, they are characteristics into the three parts, like it can be we can having the RPGN1, RPGN1, RPGN2 and RPGN3. See, RPGN1, this is what good posture syndromes. I hope you, and many of you heard about already, that is what good posture syndromes. That is good posture syndromes. That is the good posture syndromes. The good posture syndrome, remember, you can remember about the good posture syndrome because that is again also the important topic for our exam. So good posture syndromes, you can remember the 1, 2, 3, 4. Look what you need to remember, 1, 2, 3, 4. The good posture syndrome whenever becomes, so one we studied already that it is the RPGN ones. It is the RPGN ones. 2 means there is a which type of hypersensitivity is the good posture syndromes. Now let's go backward retrospectively. Keep your mind, think about the Croc ones where you was studying about the hypersensitivity. In the hypersensitivity we were studying about the there is type 1 hypersensitivity, there is a type 2 hypersensitivity. In the type 2 hypersensitivity we studied that there is a what the problem of hypersensitivity, the problem having the antibody problem. So there is a what will be there, good example of that, good posture syndromes. And the good posture syndrome, we talked that there is involvement of the basement membrane. There is involvement of the basement membrane. Here what we wrote, wrinkling of the basement membrane. So when we talk about the basement membrane, we talk that the basement membrane of the lungs and the basement membrane of the kidney. So when we are talking, if the lungs, basement membrane of the lungs was affected, then it will lead to the hematuria. But if the kidney will be there, sorry, if the lungs basement membrane affected, that is hemoptysis, blood in vomiting. But when we talk about the kidney, we talked that it will lead to the hematuria, blood in urine. I hope this one you remember. Hypersensitivity 2 we studied their example, that is the GPS. In GPS we studied that the basement membrane affected. Now here you are seeing the wrinkling of the basement membrane. Now you are seeing there is a RPGN, that is the rapidly progressive glomerulonephritis. So this is the example of the rapidly progressive glomerulonephritis in which basement membrane is affected, in which we studied that there is a type 2 hypersensitivity. The hypersensitivity type 2. I hope this is clear, and this is like the for you also, that for the for you need to be success, you need to take a little step as well. You can just take a little motivation from here, that you studied everything in the third year about the hypersensitivity and all. Now you are getting little bit extra so that you will get the more success. So that's why remember, everything will have the perfect times. So no need to worry and no need to be fast, just be patient. Now let's come back to our topic, that RPGN1, this is the hypersensitivity 2, and the third one is the, there we will see the alpha 3 chain. The alpha 3 chain, there is a alpha 3 chain of which one? Collagen. The alpha 3 chain of collagen, which one? Collagen, the 4. Okay, we have the collagen 1 type, collagen type 1, collagen type 2, collagen type 3, collagen type 4, collagen type 5. So this, out of them, the collagen type 4 is present in the good posture syndromes, and the antibody will be made. The antibody made against collagen 4. Okay, I hope this is clear. The antibody made against the collagen 4. Then RPGN2, again we can see that it's the like the progressive, what we are writing, rapidly progressive glomerulonephritis, means something is progressive, glomerulonephritis progressive, so the PSGN will be the examples. See, PSGN progress to the rapidly proliferative glomerulonephritis, that is what example of that. IgA nephropathy, that also can proliferate and convert into the RPGN2, means after the like some time or after when the complications will be there can be the breakdown of the basement membrane, there increase in the WBC, all these things can happen or the as a complications. Other than that, we can have the SLE, HSP, so all these you need to remember. RPGN3, hi sir, sorry to interrupt, when will be in YouTube play? When will this be in YouTube, please? This will be not in YouTube. You know, that I will discuss. This will not be in YouTube, and the yesterday video I will put in YouTube tomorrow morning. PSGNs, IgA, SLE, HSP, RPGN3, we have the microscopic polyangiitis. There is a microscopic polyangiitis. The microscopic polyangiitis, and we will having the Wagner's granulomatosis. There will be having the Wagner's granulomatosis. Okay, so RPGN3, we have the microscopic polyangiitis, and we will having the Wagner's granulomatosis. Okay, so this is what we have the RPGN. Okay, I hope this is clear till now. Anyone don't have any problem? Okay. So we have the RPGNs, we have the RPGN, that is good posture syndrome, PSGN, IgA, SLE, HSP, microscopic polyangiitis or Wagner's granulomatosis. They will complicate and they will form the RPGN3. This is GN. Okay, so we studied already about the nephritic syndromes. In the nephritic syndrome, we studied about the PBR. Okay, PBR. So that is a PSGN, Burgess disease and RPGNs. Now let's continue with our nephrotic syndromes. That is again the important point, MCD, minimal change disease, focal segmental glomerulonephritis, membranoproliferative glomerulonephritis, and membranous glomerulonephritis. One is proliferative, another is simple. So let's continue with the first one, nephrotic syndromes. That is the nephrotic is first one. We have the minimal change disease, MCD, minimal change disease. Okay, there is a minimal change disease. See, the minimal change disease, this is the most common in children. Minimal change disease, this is the most common in children. The most common in the children, that is which? Nephrotic syndrome. Which is the most common nephritic syndrome in the children? That is Burgess disease. That is PSGNs. The most common in the children's nephrotic. Nephrotic is what? Minimal change disease. So the minimum, so what we will see in the, we have the minimal, in the minimal change disease, we see the something like minimum means minimum means like children's we have the minimum age, so small age. This is seen, you can remember, minimal change disease, this is seen in minimum. Okay, what is the minimum? Like this is a small, like seen in the children's, you seen in the children's like minimum age you can remember like that, or the small age. The cause of the minimal change disease is idiopathic. What is the meaning of idiopathic? What is the meaning of idiopathic? The idiopathic means the disease is unknown or the cause is unknown. The etiology is unknown. That is idiopathic. Okay. So this minimal change disease, this is also known as lipid nephrosis. This is also known as the lipid nephrosis. So now understand why we call this condition as the lipid nephrosis. Why we call this condition as the lipid nephrosis? Because we will see there is a lipids in PCT. What we will see? Lipids in PCT. That's why we call this condition as the lipid nephrosis or the lipoid nephrosis. And after that, remember the important point for this, or the important keyword for these questions, that is the effacement of food process. There is a effacement of food process. These questions you already discussed. There was one questions in the croak one, so in which your keyword have the effacement of the food process. So if we are getting the effacement of the food process, that is the gold standard electron microscopic technique. Gold standard. So that is the gold standard. And this effacement of the food process, so means what we will see, there is a flattened efface. See, we are having the podocytes. We have the podocyte in the glomerular capillaries, and when these podocytes, they will, like podocytic cells, these cells, then these sites will becomes the flattened. These sites will become the flattened. So that's why we call this is known as the effacement of the food process or the flattened conditions. Okay. So these are what? These are the food process. We can also call these are the podocyte cells. These are the podocytes. These are the podocyte cells. I hope this is clear. Also, one important other keyword you can remember for the MCD. You can minimal change disease. You can remember that they have the selective proteinuria. They will having the selective proteinuria. So selective proteinuria, or we can say there will be the albuminemia. There will be the albuminemia. So there is a selective, if in the question you are getting the selective proteinuria, along with that you are getting something, the effacement of the food process, or maybe in the question they will give you about the podocytes, or maybe in the question they can give you hyaline and fatty cast, hyaline and fatty cast in urine. So also think about minimal change disease. Hyaline and fatty cast along with the effacement of the food process. Don't think about any other options. Mark the answer minimal change disease. And the treatment is what? We have the steroids. What is the treatment for these conditions? That is what? Steroids. Because they ask sometimes whenever the treatment is the steroids, normally usually they ask. And also remember the steroids we are doing here because they having like the amazing good response for the selective proteinuria. That's why we give the steroids. We studied about the child nephrotic syndromes. Okay, now let me ask you one question. Which is the only vasculitis that is seen, only vasculitis that is seen only in the like children's? Vasculitis that only seen in children's. Anyone? HSP, Kawasaki. HSP. So who is right? So Jasmine, why the HSP? HSP is not, HSP can be seen in both, and as well female or the male. So the Pragyana is right, Hamza is right, that is the Kawasaki disease. So remember the only one, that is the Kawasaki disease. You remember the Kawasaki, we will having the strawberry tongues. Bachcha Kawasaki, है ना? पान खाता बच्चा भी था. That is what? पान खाता बच्चा. So that is खाता. So बच्चा is cut. Bachcha is eating. So that's why that we studied. Chalo. So next one we have the second one. So the here we are talking nephrotic. The most common nephrotic in children, that is which one? Minimal change disease. So minimal change disease, MCD. Then other one we having, that is in adults, that is common in adults. So what is that? That is what we have the FSGS, focal segmental glomerulonephritis. Focal segmental glomerulonephritis. Okay. So in focal segmental glomerulonephritis, the simple thing is that we will see if you are getting something sclerosis, see the focal segmental glomerulo, this is not sclerosis, full form is focal segmental glomerulosclerosis. See, when we are getting the sclerosis, so remember that if in the sclerosis what we see there is a pink materials, means something like the pinkish type of the material will be there. So that is seen in the FSGNs. So what we will see in case of SGS, we will see there is a pink material scenes. What we will see, pink material will be seen. And cause of that, it can be like the HIV, it can be the hypertensions, it can be the like something heroin ho gaya, and reflex nephropathy, renal tissue loss, sickle cell anemia. All these can be the cause of the FSGNs. I'm writing something here that HIV, hypertensions, then we can even remember the reflex nephropathy, you can remember the sickle cell anemia. So these are the causes. The causes of the FSGN, HIV, hypertension, reflex nephropathy, sickle cell anemia, these all are the causes of the focal segmental glomerulonephritis. Then also remember, this is the most common cause of nephrotic syndrome in adults, that is FSGN. I already wrote it here, adults, the most common cause of nephrotic syndrome in adults, that is FSGS. Okay, so this one you need to remember, and also along with that you can remember on microscopy. On microscopy you also remember there is a focal segment sclerosis will be there, focal segment sclerosis, that's why we call this is FSGS. And there also we will see hyalinization of the glomeruli, hyalinization of glomerulus, and there will be the lipid droplets will be there, and there will be the lipid droplets will be there. So on microscopy what we will see, there is a focal segment sclerosis and hyalinization of the glomeruli, and the lipid droplets will be there. Okay, this you need to understand about the focal segmental glomerulonephritis. Now the next remaining one, we have the two more remaining, that is the membranous proliferative glomerulonephritis and membranous glomerulonephritis. See, membranous glomerulonephritis, if we talk, membranous glomerulonephritis, third one we have the membranous glomerulonephritis. The membranous glomerulonephritis, see, this is the most common in elderly patients. So if you have the elderly patient, that is the most commonly seen in case of the elderly patients, and this is the form of chronic immune complex mediated disease. It is the form of chronic immune complex mediated disease, the form of chronic immune complex mediated disease. Okay, so this is what membranous glomerulonephropathy or glomerulonephritis. In MGN, so that it can be like we have it can be the primary or it can be like the secondary. If it is caused by the or there will be the antibody formations against the phospholipase A2 receptors. We studied in the, remember for the about the CROC one, again we studied that there is something enzymes phospholipase A2. Can you just tell me this enzymes we used in which pathway? If anyone remembered, that will be the like very good. Phospholipase A2. Yeah, Lux now. So that is Lux. He's right, but that is a LOX COX. That is COX pathway and LOX and COX pathway. So that is the phospholipase. When we are doing the arachidonic, or we can say it is the arachidonic acid metabolisms. In that condition, we are doing the phospholipase A2, and also we use the steroids here to inhibit the phospholipase A2. And we have the COX pathway, that we have the COX1, COX2 and COX3. In the COX1, which drugs is there? Non-steroidal anti-inflammatory drugs. Then COX1, we have the non-steroidal anti-inflammatory drugs, like we have the indomethacins, we have the aceclofenac, we have the diclofenac, we have the aspirin. So these are the COX1. COX2, we were having the The drugs like, what the drugs? What drugs? Rofi, Toffee, all these were the Roficoxib, all these were the COX-2 inhibitors, but Rofi and all these were like withdrawn because of myocardial infarctions. Then COX-3 we studied, then COX-3 we will having the paracetamols. So this was the COX-3 inhibitor. Okay, so I hope you, just for recall, because the drugs they can ask you, not the similar drugs, but you should have the retention of everything so that you can connect your neurons to each other. So there can be the in the primary there can be the antibody. This is AB is much antibody. The antibody against phospholipase A2. The only antibody against the phospholipase A2. See, if you don't know any full meaning of the any like most common, this is the most common, maybe because you don't know, don't use this type of the term, so just ask me. Like you don't know about the GABHS, so if you don't know these things, just ask me, I will repeat it. The antibody against the phospholipase A2 receptors. There can be the antibody against the thrombospondins. Okay, just remember, if we call this condition as the primary. But if it is caused by the drugs like NSAID, penicillamine, that is penicillin drugs, you know, vodka and all those drugs, penicillamines. Okay, and it can be caused by like some infections like hepatitis B virus, HCV, syphilis, malaria. All these can also lead to the, we call this condition as the secondary membranous glomerulonephritis. So this can be asked, this can be the ask as a, both options can be given in the questions. So if membranous glomerulonephritis, this is the most common in elderly patients, the form of chronic immune complex mediated disease. Then antibody against the phospholipase A2 receptors, the antibody in antibody against thrombospondin. So this is against like the similar. The drugs we use, that is NSAID or the penicillamines. Infections we have the HBV, HCV or syphilis. They will all will cause the secondary MGN. I hope this is clear. In the questions you will get the keywords. After once everything will finish, I will highlight some important points so that you will get the idea and you will definitely get the those keywords in your questions. So on microscopy we will having the spike and dome patterns. We will see the spike and dome patterns on microscopy. What we will see, we see the spike and dome patterns. So there is a, like something like irregular spike. We can say there is a irregular spikes from the basement membranes. Irregular spikes can be there. Okay, then on we studied about there is a subendocardial, there is a or endothelial deposition that is seen in the case of PSGN. But here we are talking about the on electron microscopy. What we will see, subepithelial depositions. The subepithelial depositions. Okay, this we or subepithelial means below the podocytes. Below the podocytes we are getting the subepithelial deposition that is seen in case of the minimal change disease. Okay, the next one we have, that is the membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis, this is the last one. So membranoproliferative glomerulonephritis, remember it is again the two types. Again that is the two types, MPGN1 and MPGN2. Membranoproliferative glomerulopathy. So that is GNs, membranoproliferative glomerulopathy. So MPGN1, it shows the tram track appearance. Shows the tram track appearance. It shows the tram track appearance. Did you study anywhere about, like yesterday before previous classes, there is a tram track appearance, something like that? Anyone knows? Ankylosing spondylitis we studied. Okay, if you remember, if you think in your mind, yes we studied somewhere, that's the good sign. So BM means basement membrane, the basement membrane is there, so that will be divided, and that this basement membrane will be divided into the two parts. Basement membrane will be divided into two parts. The basement membrane, it is divided into two parts. That is MPGN1. So this shows the tram track appearance. So we have the basement membranes. So what they do, it will divide it into the two parts. In MPGNs2, remember they have the MPGNs2. This is note will be asked. If they will give you the questions, they will give you about the MGN, not about the MPGNs. In MPGN, if they want to give, they will give you these things. MPG2 they will not give, and if they will give you, so you need to remember that it will be the persistent. Just remember one keyword here: persistence hypocomplementemia. See, we have the complement C1, C2, C3, C4. So the hypo, that complement level will be low in our bloods. That you need to remember. And also remember about the MPGNs2 on microscopy. On microscopy, you will see the dense deposition. There you will see the dense deposition. Okay, so what we will see? We see there is a dark colored urines. We see the dark colored urines. Okay. And I hope you wrote everything. Now tell me about if we having the MPGN, mesangial cells, if you having the mesangial cells, mesangiums. So in the mesangium there is a deposition of, like quick summary, you can write it as quick summary, deposition of IgA, and this is in Buerger's disease. This is in Buerger's disease. Okay, intramembranous, or we can say that there is a dense deposit. Intramembranous, there is a dense deposit. So again, this is seen in case of MPGN2. This is seen in case of MPGN2. Then the next one, we have the subepithelial. The next is what? Subepithelial. The subepithelial below the podocyte. So this is seen in PSGN and membranous glomerulonephritis. Then we studied subendothelial depositions. So subendothelial depositions, this is seen in case of MPGN1. This is seen in case of MPGN1s. And subendothelial depositions, remember yesterday we studied about the SLE. They were studied about the SLE. So in the SLE we studied that, I think we didn't write wire loop lesion yesterday. Okay, so the wire loop lesions, that will be the subendothelial. This will wire loop lesions where it will be subendothelial. So write there in SLE wire loop lesions. That you already know, so need not to worry. So now let's come back to our topic, nephrotic syndrome or nephritic syndrome. See, this is clear. Nephrotic means, oh my god. So massive proteinuria, lipiduria, hypoalbuminemia, edema is there, thrombotic event will be there. Okay, now stop writing. Don't write. Okay, stop writing. Just listen me and speak out with me. Just listen me and speak out with me. Please stop writing. See, post-streptococcal glomerulonephritis. The post-streptococcal means after the streptococcus, pharyngitis, pyoderma, impetigo. I am highlighting the point. You should also highlight that point. If we are getting the pharyngitis, we are getting the pyoderma, we are getting the impetigo, we are getting the glomerulonephritis. Okay, so there will be the immune complex deposition. There will be the immune complex depositions in the kidney, and that will be the glomerulonephritis. See, gross finding we see in this condition, that is the flea-bitten kidney. Which kidney? Flea-bitten kidney. Pinpoint hemorrhage. Flea-bitten kidney, pinpoint hemorrhage. Starry sky appearance, subepithelial humps or deposit. Starry sky appearance, subepithelial humps or the deposit. Now repeat with me: flea-bitten kidney, subepithelial hump or the podocytes will be deposited, and the starry sky appearance. This is seen in case of PSGN. This is seen in case of PSGN. Next one, Berger disease. Berger disease also known as IgA nephropathy. Berger disease also known as IgA nephropathy. Berger disease also known as IgA nephropathy. The most common nephritic syndrome in adults. The most common nephritic syndrome in adults, that is Berger disease. B for बड़ा, P for बड़ा, ठीक है, कुछ अलग मत समझ जाना, ठीक है. That is B for बड़ा. बड़ा means adult, so that is बड़ा, यानी कि B for big, है ना. Big, that is most common nephritic syndrome in adults or the big persons. The most common all over the world, that is Berger's disease. What is the etiology of the Berger disease? So remember, that is the group A beta hemolytic streptococcus, same as post streptococcal glomerulonephritis. The microscopically, there is a IgO deposition in mesangium. There is a IgA deposition in mesangium. So remember, if there is a mesangium, think about Berger's disease. Mesangium, think about Berger's disease. PSGN, it takes 10 to 14 days, and then there will be the hematuria. PSGN, there will be the 10 to 14 days. PSGN, 10 to 14 days, hematuria will be there. Berger's disease, there will be the hematuria after the 3 days. After the 3 days, in the big person, everything will be fast. So G for jaldi jaldi. G for jaldi jaldi, or jaldi jaldi means fast. Okay. RPGN, rapidly progressive glomerulonephritis. So in the question, if you are getting the crescentic glomerulonephritis, or half moon shaped, so means that is talking about the RPGN. If you are getting the fibrin in the questions, you are getting the leukocyte in the questions, you are getting the parietal cell is more than the visceral cell. Everything you will see in the keywords as a keyword in the questions. Maybe you are getting something like crescentric, you are getting there is a leukocyte level is increasing, parietal cell is more, there is a basement membrane is rupturing, or there is a wrinkling of the basement membrane. Since there is a damage of the basement membrane, that means you need to think about what rapidly progressive glomerulonephritis. If there is a damage in the basement membrane, you need to think about rapidly progressive glomerulonephritis. See, hypersensitivity to, we studied that that is the example of the hypersensitivity to example, that is the GPS. In the GPS, we studied that there is a basement membrane is affected, and the basement membrane, if the lungs basement membrane is affected, there will be the hemoptysis, means vomiting will be there. But the blood in vomiting will be there. If there is a basement membrane of the kidney will be affected, so there will be the hematuria. What will be there? Hematuria will be there. RPGN, that is the rapidly progressive glomerulonephritis. So in the RPGN1, there is a good pasture syndromes. We will see there is a RPGN. You need to remember this one. Good pasture syndrome. Remember 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3 pair RPGN1 hypersensitivity to alpha 3 chain of the collagen 4, and antibody will be made against the collagen 4. Okay. Then nephrotic syndrome. This one was the nephritic. In the nephritic, we studied PBR. Then we have the nephrotic syndrome. See, in the nephrotic syndrome, we will be having the minimal change disease. Nephrotic syndrome, we will be having the minimal change disease. Minimal change disease, remember, that is the minimum changes. Minimum means most common in the children. Children is minimum age, so most common in the children's. What is the cause of the minimal change disease? The cause is unknown, and what we call this condition as the idiopathic condition. What we call is the idiopathic condition. Okay, tell me, who will tell me what is iatrogenic? Sometimes we write idiopathy, sometimes we write iatrogenic. So what is the iatrogenic? Iatrogenic. I'm telling idiopathic is unknown, but what is the iatrogenic? IATROGEN, due to surgical errors. Whatever the errors we are doing, that is what iatrogenics. Maybe errors due to any doctor, may error due to any medical staff. So that is what we call this condition as the, yeah, that cause due to some mishaps in the hospitals. So there is a medical problem will be there. So that is what iatrogenic there. Okay. So here we have the idiopathic, that unknowns. Then also known as the, this is also known as the lipoid nephrosis. This is also known as the lipoid nephrosis. Lipoid nephrosis means that lipids will be deposited in the PCT. In electron microscopy, what we will see, effacement of the food process. If you are getting the effacement of the food process or the podocyte in the questions, or the flattened, effacement means the podocyte, they will become the flat. So that is what the minimal change disease. In the minimal change disease, there is a selective proteinuria. In nephrotics, sir, we studied that there is a massive proteinuria, but in minimal change disease, there is a selective proteinuria. Means you need to remember that is selective proteinuria means albumin will be less, only the albumin. Plus we will see plus hyaline and fatty cast in the urines, hyaline and fatty cast in the urines. And what will be the treatment for this? The treatment will be the steroids. In adults, what we will see, in adults what we will do, FSGN, focal segmental glomerulonephritis. Focal segmental glomulosclerosis. Sclerosis means pinkish type of the material. If this is my blood vessel, this is my tunica media and intima. I hope you know tunica adventitia, tunica media. Then we have the tunica media. We are getting something here, the pinkish materials. We are getting here the pinky promise material. Pinkish material. That is what sclerosis, and the cause is HIV, hypertension, reflux nephropathy, and the sickle cell anemia. On examinations or microscopy, what we will see, we see there is a focal segment sclerosis or hyalinization of the glomeruli, and there will be the lipid droplets will be there. Then we have the membranoproliferative glomerulonephritis. In the membranoproliferative glomerulonephritis, this is the most common membranoproliferative glomerulonephritis. This is the most common in elderly patients. So if you have the elderly patients, that is what MGN, membranous glomerulopathy, the form of chronic immune complex deposition. So that is mediated disease. If there is a chronic conditions and elderly patient is given, whatever you are thinking about, just mark the MGN. Primary, it can be the antibody due to antibody against the phospholipase A2 receptors, antibody against the thrombospondins. Then we have the drugs like NSAID, penicillamine, or the gold also. All these will cause the secondary MGN, and the infections like the hepatitis B virus, HCV, syphilis, all these cause the secondary membranoglomeraphritis. On microscopy, what we will see the spike and dome pattern, or what we will see, irregular spikes will be there. On electron microscopy, we see there is a subepithelial deposition. On electron microscopy, we see subepithelial depositions will be there. Then next one is membranoproliferative glomerulonephritis, which shows the tram track appearance, which is there is a MPGN persistent hypocomplement level will be less, and there is a dense deposition, so dark colored urine will be there. And this one we did the summary, and the subepithelium that is seen in PSGN, MGN, subendothelial, remember, that is seen in MPGNs, or the SLE, that is the wire loop kidney, we will see. I hope this is clear. Done. Okay. So this one we have the acute glomerulonephritis. So glomerulonephritis, if there is inflammations, just I'm giving you 2 minutes, revise everything and take a like small water break, drink water and all. Just 2 minutes break, don't left. Okay, so let's come back. Okay, this is what we studied, acute pyelonephritis, and now let's continue with our next topic, that is 8. See, when we are talking about the 8-year-old boy has suffered from the tonsillitis. So this question we already discussed, but we didn't discuss the treatment. So the tonsillitis, in the 2 weeks he started complaining of migratory joint pain, edema of the joint, restriction of the movement. And on examination there is acute rheumatic heart disease, activity of the third degree, primary rheumocarditis, polyarthritis, acute course of the disease, cardiovascular failure. 2A, what medication is to be prescribed? See, normally I told you the drug of the choice is the benzathine penicillin. I told you the benzathine penicillin. Okay, but here answer you can give as the prednisolone. Prednisolone is what? Steroids. It is what? It is what? It is what? Steroids. Prednisolone, it is what? Steroids. Okay, this is what? Steroids. So we can having the like this type of the steroids. What these are like used for the they are the inflammatory drugs. Like you have the non-steroidal anti-inflammatory drugs. So they are also the anti-inflammatory drugs. That's why in the rheumatoid arthritis, what we will see, we see there is a conditions like the inflammations of all these things, due to which we can prescribe the treatments as the steroids as well. So if you're getting the in the questions the any steroid drugs, you can mark that. But the drug of the choice for that we already discussed are the prophylaxis. As a prophylaxis, we can give the benzathine penicillin. Okay, I hope this is clear, no doubt. See the question number 9. A 10-year boy has a complaining of headache, weakness, fever. Weakness, fever, 40 degrees Celsius, there is a vomiting. So we can get there is a fever, okay, vomiting, express dyspnea, and there is a 10-year-old boy. Sometimes the age can give us the best answer. Okay, pale skin with a flush on the right cheek, lag of right hemithorax, respiratory movement, dullness on percussions over the low lobe of the right lungs, weakness of the vesicular respiration in this zone, the abdomen is painless and soft at palpations. So, which disease led to these symptoms and signs? See, if you don't know anything, so what you will mark the answer? Can you mark this answer as acute appendicitis? Can you mark this as acute appendicitis? I hope no. Because there is nothing about appendicitis. In appendicitis, they will give you migratory pains. Like if there is a pain in the epiglottis, in the regions, in the hypochondrium regions, and there will the migratory pain. After that, there is a pain we can see in the left lumbar compartments. So there is other signs we will also see, but it can be the intestinal infections. Did they give anything about related to the GIT and all? No. Can it be the flu? Flu is what? This is the like common cold, or it can be like the influenza virus. So this is nothing about the. Can it be the acute cholecystitis? Can be it be the acute cholecystitis? In acute cholecystitis, what we will see, at least you know we have the gallbladder hair. We don't have the gallbladder hairs, है ना? So they are talking about the lungs, and so direct questions you can see there all the 4 options rule out if you didn't know anything as well. So the answer for these questions will be remaining as the pneumonia. So what is the pneumonia corposa and what is the pneumonia? See, when we talk about the pneumonia, so there can be like the corpus pneumonia. So it can be the lobular pneumonia. It can be the lobular pneumonia, or it can be we have that is the bronchopneumonia as well. So let's first discuss. This is also we can call it as the lobular pneumonia. Lobular pneumonia. This one we can also call it as the lobular pneumonia. And this lobular pneumonia, or we can say the focal. See, we have the some, like if I will say, this is my lungs. Okay, this is my, sorry. We will be having some lungs. Okay, like this lung. So if I'm saying that this is what we have the lobes, so if any particular lobe is affected, so we call this as the lobular pneumonia. And this lobular pneumonia, there will be the consolidation will be there, and there is, this is what they have the acute development. It can having the entire lobe involvement. It involves the entire lobes by any process of inflammations. See, there is a things like we already studied in during our third year. There is a we have the right lungs or the left lungs, the right lungs and the left lungs. In both those things we studied about the lobes. So we have the like upper lobes, we have the middle lobes, and we have the lower lobes. One have the 2 lobes, one we have the 3 lobes. Then remember we have the 10 segments, the 10 segments. So we have the lobes. If any lobe is affecting due to any inflammatory process, lobe affected due to any inflammatory process, See, lobe affected due to any inflammatory process, that is what pneumonia cruposa or the lobular pneumonia. Now in the questions you can see there is somewhere you can see the dullness. We know the percussion. The percussion is done on the middle fingers by the middle finger. Percussion, remember this is like clinical point. You can remember for your future. Percussion is done on middle finger by middle finger. Percussion is done on the middle finger by the middle fingers. I hope I am visible. So middle finger, I am not showing you the middle finger. So it is seeing them like we have the middle fingers by the middle finger. So that is we do the percussions. So we will having the dullness. See, there is a one dull. We will see the dullness. The dullness means that we have the dense tissue is there, and dullness we can see in the like if we have the tissue will be having the dense, so the lungs will be the dense. We will hear the dull sound. And other sound we can hear, that is the tympanic sound or the resonant sound. The tympanic or resonant sound. See, this type of the sound we hear when there will be something like we have the not dense sound, not dense things will be there. Like we have some little air will be there. So in that conditions we can having the tympanic or the resonant sounds. Like in the case of pneumothorax. So we can having the tympanic sound or the resonant sound or the hyper resonant sound. So resonant or the tympanic, this is the normal. The normally we have the less dense tissue in our lungs, so we will get the tympanic or resonant sounds. This can be the normal, or this can be like hyper resonant if is there, means something the less dense, very less dense structure is present. And if there is any dense tissue or the like water is there, or the any air or the dull things is present, so it will give the dullness sounds. Okay, as the questions will progress, you will able to understand that it easily. Now let's continue with about the pneumonia. Okay, little bits about everything about the pneumonia. See, pneumonia we studied that. Also remember this pneumonia. It is the important cause or the main cause of the under 5-year mortality. Like the children who was under the 5 year, the pneumonia is the most common cause of the death. Under 5 mortality. Mortality means death rate. So what happened in the pneumonia? There will be the consolidations. Means the one lobules will be gone. So the consolidations of alveoli, or there will be the inflammation of the inflammation of the interstitial tissues. What is the interstitials or what is the intra? I hope everyone is cleared about it, or if you don't clear, see this example now I cannot give, or you can remember it like this. We have the 2 box, or you can remember it as the 2 trains, one train, and between the train we have the some space. Between the train we have the some space, or you can remember it, we have the two box. In one box you are sitting, in another box I am sitting. So we are in the intra, means inside the inside. So this is my like cell, this is my another cells. Here I am sitting, here you are sitting. So we are both are the intracellular. So this is, and between them everything is present between. So that is the intercellular. So that means we have the interstitial tissue, means presents between the different type of the cell groups. There is just some space will be there, that is the interstitial tissue. So that will be inflamed, and there can be the alveoli that will collapse, or they will having the consolidations. So that will cause the pneumonia. Which is the most common bacteria overall? Which is the most common bacteria overall? Most common, this is most common bacteria overall. If you know something, write in the chat box. Yes, that's good. Thank you. That is Streptococcus pneumoniae. Streptococcus pneumoniae. Okay. Which is the most common cause? This is MCC is the most common cause of pneumonia in neonates. The most common cause of pneumonia in neonates. What is that? That is like gram-negative organisms. These are the what gram-negative organisms? Gram-negative organisms. This is organism. What is that? Like Klebsiella. Like we have the Klebsiella. We have the E. coli. The Klebsiella and E. coli. The most common cause of pneumonia in neonates, that is the gram-negative organisms, Klebsiella or the E. coli, and also there can be Staph aureus can be there. Okay, if I ask you which is the most common virus that cause pneumonia, that is respiratory syncytial virus. Writing it full form, respiratory syncytial. Yes, you are right. Respiratory syncytial virus. Syncytial virus. Now they will ask you about the community management, like guidelines, management, about the management. So yeah, like how you can manage the pneumonia. So for the management, like if the patient having the no pneumonia, if the patient will having the, you will get the some, according to the WHO, you will get the some kit as well, like pink kit, you have the yellow kit, or based on that you need to give the that. For that, for here they will not ask you. They will ask you simply if you have pneumonia. You have the no pneumonia. No pneumonia means the person will having the fever, this person will having the cold, and this person will having the cough. And so in that conditions, what you will give? Our universal drugs, that is oral paracetamol. Oral paracetamol. That is, if wheezing is present, so what we will give? We will give the salbutamol. What we can give? Salbutamol. Yesterday we also discussed aminophylline, salbutamol. So all these things for at least minimum for the 5 days. That you don't need to remember, but you need to remember if wheezing is there, we can give the salbutamol. But if the person is having the pneumonia, but that is the mild pneumonia. In the pneumonia, like person will having the fever, this person is having the cough, this person is having the cold, this person is having like there is a, we can see yesterday I told you. So there is a fast breathing. So when the fast breathing is there, the chest is indrawing, chest is going up and down. So that is what we have the breathing patterns. There is a fast breathing is there. Fast breathing is there. Plus there is a chest indrawings. Chest indrawing. Chest indrawing, or we can say this patient will having the, he's taking the, so he is taking the fast breathing. So but there is a patient having the no hypo, no oxygen deficiency is there. So no hypoxia. So that is mild pneumonia. So in that conditions we can give the oral paracetamol. Along with that we can give the salbutamol. Salbutamol when we will give? If wheezing is present. Wheezing means like whistling sound is there, then we can give the salbutamol. And along with that we can give, need to give now the oral antibiotic, because if there is a chest indrawing, there can be the high possibility of the much bacterial infection. So we need to give the oral antibiotics, and if pneumonia is there, it means the patient is having some bacterial infections. So for that, along with they need to give the oral antibiotic. That what we can give, amoxicillin. What we can give, amoxicillin. Now from your relatives point of view, see, from your relatives point of view, relatives, sometimes what happen, your relatives or any your close ones, they can ask you, you are the medical student, you can have you are the doctors. Chest indrawing means chest is going up and down. There is a movement of the chest, hyper movement of just like if you are taking, I hope you are able to see, if I am taking the fast breathing, so there is a indrawing of the chest. What we have writings, we have already given there is a pneumonia is condition. So if there is a bacterial infection is there, that of course that we need to check if it is virus or anything. But if we have the possibility, see, we are not in the hospital now, we can't check anything, say is it virus or is it bacterial infections. We have just pneumonia, whatever the pneumonia is it. If it will be the virus, antibiotic might not be effective, and it can lead to the severe pneumonia. The further it will can increases. Not due to antibiotic, but we are not giving any drugs. And if that will come, we will comes. See, if you from your relative point of view, any person having the pneumonia and these type of the symptoms is there, like the patient having the fever, the cough, and the coryza. So we can firstly we will give the paracetamol. If the person will not treat with the paracetamol, we can give the patient having the something like normally in the like in our country, in my country we will give the if the person will having the cold as well, so we can give the citrazines. We can have the any antibiotic, they will say give me any antibiotic so I can treat. So antibiotics you can give like the amoxicillins. Amoxicillin plus clavulanic acid, this is the best antibiotics that you can give. Okay. See, if this pneumonia is there and we will having the oral PCM, salbutamol, oral antibiotic, or amoxicillin is given, then after that we will be having, like if the person will having the severe pneumonia, if the pneumonia is not treated and it further complicated into the severe pneumonia, or we can having we can call this very severe disease is there. So like that it will be possible, all these symptoms will be there, the fever will be there, then we have the cough, the cold, fast breathing will be there, the chest indrawing will be there, but in pneumonia there was a no hypoxia, no oxygen requirement. So here what we are having, the hypoxia will be there, and the oxygen saturations, what we will see, SpO2, the SpO2 will be level will be less than 90%, and the person will be having the stridor, in the calm child. See, normally the pneumonia persons, it is not about the virus and all. The antibiotic will not work. So the pneumonia is not a like it can happen in everyone. Like you can see in the childrens, it is very common. So that is the or it can be subsides in minimum 5 to 7 days or within the less than that. But if it is converted into the severe pneumonia, like there is a stridor in the calm or the stridor and then the calm child. Like stridor means there is some sound is producing during the inspirations or during the expirations. If I am taking the like something inspiratory stridor, this is the inspiratory stridor. We are taking the sound, this whistling sound will be here during the inspiration. That is what stridor. So there is a stridor in the calm childs, and we can having some other danger signs. What are the danger signs we having? The baby is not feeding. The baby is not feeding, or the patient is not feeding, patient is not drinking. Then having every time we have the lethargic conditions. At that times we will we need to give the ampicillin or oxacillin. They are the same drugs, same family, ampicillin, oxacillin. Along with that, we need to give the aminoglycosides, that is gentamicins. And this is very important drugs for the pediatric pneumonia. If in the questions there is a pediatric pneumonia is mentioned and there is a children's like around 10 years or 9 years, so we need to give the oxacillin along with the aminoglycosides like the gentamicins. Along with that, if we will give the first line drugs and then we'll refer the patient to the hospital. Okay, this is the different, can be different from different countries. So remember these things. If you have the severe pneumonia, we need to give the, every times whenever we are suspecting something, we need to give the first line drugs. In every conditions, we have all having the first line drugs. We cannot have, we have the monosaf. Monosaf is ampicillin or monosaf drugs. Then there is a one more drug like monosaf salbactam. So first line drug monosaf salbactam is more than very good drugs and better drugs than the monosaf. But for that we need to give the monosaf first. After that, because that is the first line drugs we need to give to every patient when the patient is coming and based on his severity. And after that we can go for the monosaf salbactams. So we need to first treat any patients with the help of with the first line drugs. Okay, so we have the severe pneumonia, that is very severe disease. Hypoxia is there, stridor in the calm child, the danger sign, not feeding, drinking, and the lethargic is there. Amoxicillin, we can give the ampicillin, oxacillin. What will be the X-ray pattern? When we are seeing the X-ray, see, I'm sending the images, sending one images in the group. You can see this image that we have the lobar consolidations. We have the lobar's consolidation. What is the lobar consolidations? On the right lungs, you can see there is some whitish space. So that is what lobar consolidation. That is what lobar consolidations. And okay, I hope this is clear. So this is what we call this is the lobar consolidations. On X-ray we see that is the lobar consolidation. And sometimes we will see the rusty sputums. Sometimes we see the rusty sputums. Now this is if in the like in the neonates or childrens, they will swallow that sputum. So we will not able to see those that things, but we will see the rusty sputums, and this you can find in the some as a keyword in the questions. If there is a staph aureus, if there is a staph aureus is there. See, if there is a staph aureus, so always remember there is a bilateral patchy consolidations. There is a bilateral patchy consolidations. Means on the both sides there will be the patch like. If I am saying, this is my lungs on the both sides, so we will see there is something like patchy consolidations will be there like this. This will be all will look like the white patches. This is all the patchy consolidations. Along with that, you can see the pneumatocele. Pneumatocele. What is pneumatocele? Seal is what? Space. Pneumo means air. Pneumatocele. That's why you call the air-filled space. Pneumo means space. So that is what air-filled space. The air-filled space is what? That is pneumatoceles. When this pneumatoceles, it will rupture. When this pneumatoceles will rupture, it will lead to the pneumothorax. What is pneumothorax? What is hydrothorax? What is hemithorax? Just get little idea. We will discuss it further. See, pneumo means air. Pneumo means air. So whenever the air will be filled in the lungs, or whenever the air will be filled in our like any of the lungs or any part of the lungs, we call this condition as the pneumothorax. But if there is a water or any blood is there, so we call this condition as the hemithorax. Hemi means blood. So if, or we can call this condition as the hydrothorax. If water in the lungs we call, or water is filled in the thorax regions, we will looks like the whole things will be looks like the whitish. If hemi in hydro, whole things will be looks like the whitish. But if we are getting the pneumothorax, everything will be looks like the black. Air on X-ray looks black. Again, they will not give you image, they will write this thing. So air on the image will be looks. Air on the image on the X-ray, they looks image. Fluid or air in the pleural layers. Yes, the fluid or air in the pleural, not in the pleural layers. Maybe it in the whole lungs it can be filled. The hemithorax or the hydrothorax. Then it can be the hydropneumothorax. Hydropneumothorax. All these images I will share in the group after the class. So, but for now you need to remember the theoretical. From the theory point of view, you need to retain this thing in mind, because this theory they will give you. They will not give you image, but after that I will send you so that you can easily remember, recall it for the later time as well. So hydropneumothorax means water is there plus air is there. The water is there plus air is there, that is the hydropneumothorax. That is hydropneumothorax. That is what hydropneumothorax, water and plus air. See, if like the same lungs, if this lung is there, okay, and so let me make it here, this ones, not a so good lungs, opposite, just consider this is the lungs, है ना? So we don't have the black highlighter. See, if this is the black color, just imagine this is the black color. See, we have this color, this is the black one, the black regions. So we can see that this condition, this wall is the black color and it is the pneumothorax. The lungs will be looks like the black, and also remember this is what white is. This is the whitest color. This is the whitest color. No. Okay, leave it. So this is what, this is again the whitest color. This is the whitest now. So this is the whitest color. The hair will be the white. So means we have the, this is the hydrohemothorax and this is what we have the pneumothorax. So this is, both are the things, air is there, fluid is there. We call this condition as the hydropneumothorax. I hope this terms is clear to you, so that whenever these terms will come in your, comes in any topic or further topics will come, so you will not able to, you will not have any problems. Okay, I hope this is clear. And also remember one thing here, the pneumatoceles, this is can be seen. So whenever if you are getting the something in the questions, pneumatocele, the pneumatocele, remember this is the Staph aureus associated pneumonia. The Staph aureus associated pneumonia. Staph aureus associated pneumonia. There can be having the Klebsiella. There can be having Klebsiella, and they will be having the about the like hydrocarbon poisonings. So all in these conditions we will see hydrocarbon poisonings. Okay, so remember the Staph aureus associated or the Klebsiella, what we will see? We see the pneumatoceles. What we will see? The pneumatocele. Okay, I hope this is clear. Then remember, if we having the pediatric pneumonia, if we will having the pediatric pneumonia. So the pediatric pneumonia, remember one drugs, that is Mpox. Now the questions will come. Mpox. Mpox is the other name of oxacillin. Mpox is the other name of oxacillin. Plus we have the aminoglycosides. And aminoglycosides like gentamicin, streptomycin. These are the aminoglycosides drugs. So what drugs we can give? We can give the gentamicin. So we can give these drugs as the oxacillin, or if no oxacillin, we can also give the amoxicillin. I hope this is clear, everyone. Okay. Okay, so this is what we have, the dullness on the percussion over the lower lobe. So we have the something symptoms of the lag of right hemothorax, respiratory movement. Then we have the dullness on the percussion. So dullness on the percussions means air is there, so that's why we can having the pneumothorax like properties. The abdomen is painless and the soft at palpations. So this condition is known as the lobular. If the lobular consolidation is there, that can lead to the pneumonia cropotia or the lobular pneumonia. We can also call this term as the bronchopneumonia. I hope this is clear. Done. Okay, now let's see the next questions. A patient with the acute respiratory viral infections. There is third day of disease. What is the third day of disease? See, all these diseases we will study. There is, we have the one first day of the disease, third day of disease, and the third day of disease normally we have the rubella. Third day of disease is known as the rubella, and we know that is the viral. It's caused by the viral infection. So remember the rubella. The complaints of the pain in the lumbar region. So there will be the pain in the lumbar regions. Okay, there is a nausea, dysuria, oliguria. Urine analysis shows the hematuria. Specific gravity, the blood creatinine levels, potassium level make the diagnosis. So if you are getting the hematuria in the questions, if you are getting there is a oliguria, all these are the symptoms of the interstitial nephritis. So let's discuss what is the interstitial nephritis. First of all, this acute interstitial nephritis, this is an example of the on the same page. So the next topic is what we have, the acute interstitial nephritis. Acute interstitial. If anyone wants break, because we will be having I think 12:30. Okay, no break. The acute interstitial nephritis. The acute interstitial nephritis is what? Type 4 hypersensitivity. See, if you are watching this and if you are studying, make sure that you are doing it perfectly. Whatever I am saying, you are listening that it very like 100% with your full attentions. Then nothing should be in your minds, whatever will be in the future. Whatever I will do, whenever I will pass the croak to, whenever I will get the degree, whenever this thing, whenever I will do these things, what will be in the how I will get my license exams in India, how I will clear my license exam, how my father is doing, what my father is doing, what my mother is doing. Forget everything. Just focus now, whatever you are doing. So make sure that whenever your mind is diverting, say that just focus now. We will discuss it later on the night. During the night times we will discuss, but now just focus. Or after the class we will discuss, after the exam we will discuss. Till then just be calm. So acute interstitial nephritis, remember this is what? Type 4 hypersensitivity. This is what? Type 4 hypersensitivity. Type 4 hypersensitivity. See, type 4 hypersensitivity we know that is due to, it is what type of the hypersensitivity? Let me ask you, what type of hypersensitivity? Type 4 hypersensitivity, which cells are involved? Ekdam clear. Oh, everything is clear from your mind. Yes, T cells are involved. And this is what? The delayed hypersensitivity. So the T cell, we know that in the T cells, the marker of the T cell is the CD4 positive cells. So in the CD4 we have the T cells. See, these are involved the T cells, and the T cells we have the CD4 and we have the CD8. Okay, the CD4 and CD8, these are the markers. So you need to remember here that there is the CD4 positive in the intestines. That there involved the CD4 positive in intestines will be there in case of acute interstitials, sorry, not in the intestine, interstitiums. In the interstitium, what is the interstitiums? The space, like the space presents between the different type of the renal cells. The space between that is known as the interstitial spaces, or that cells present here, the interstitiums. So there is a CD4 count will be deposited here in case of the interstitiums, and this is the reversible cause of acute kidney injury. This is the reversible cause of acute kidney injury. This is the reversible cause of acute kidney injury. This is often due to, immunologically induced hypersensitivity. Immunologically, which immunologically? T cells. Immunologically induced hypersensitivity to drugs. Immunologically induced hypersensitivity to drugs. Okay, this is hypersensitivity here. Hypersensitivity to drugs. So this is often due to immunologically induced hypersensitivity to the drugs. What type of, like any drug, NSAID or endomethacins, what any drugs, they can cause the acute interstitial nephritis. The symptoms mainly, they are the asymptomatic, they don't have any symptoms. There is a no edema or no hypertension. There will be the no edema, no hypertensions, usually asymptomatic. Usually what they are the asymptomatic patients. The symptoms will be no. The rashes we see in this condition, this is the most common rashes we see. This is the most common extra renal symptoms. The most common extra renal symptoms we see in this cases, that is the rash. Or we can see there will be the Dr. Ashish also joined. This is the from integrated learning. Or we have the eosinophilia. Okay, so we having these patients will having the most common extrarenal symptoms, that is the rashes, or we will having the eosinophilia will be present. And what type of the rashes they have? They have the maculopapular rash. What is the maculopapular rash? Macules is there and papules will be there. That is what we have, the maculopapular rash or the eosinophilia. There will be the renal impairment after. The renal impairment will be there. See, there is a nephritis. So nephritis means there is inflammations. That's why you can remember it as there will be the renal impairment. So renal impairment will be there. So renal impairment always will be after taking the drugs, or after like the drug has been after the cause of the drugs, like the drug has started and that causing the renal impairment, or that will cause the nephritis, that after drug has started. You can write it like this. What will be the lab findings we will see? Lab findings. What the lab finding you will see? See, you will see the proteinuria. What you will see? Proteinuria. The proteinuria. And this is what? Mild proteinuria. Mild proteinuria will be seen in case of acute interstitial nephritis. You will see there is a WBC in urine. Is it? See, look, most probably the similar like the pyelonephritis. The pyelonephritis we see there is a WBC cast. Here we are also seeing the WBC in urine. Along with that we will be having hematuria, but that can be present or that can be absent. There will be the oliguria, means urine level will be decreased. There will be the CD4 T cells. You remember CD4 T cells in interstitiums. This one is very important point. There will be the patients will be having, finally there can be the renal failure can be possible. The patients can having the pyuria. What is the pyuria? Pus in the urine, that is the pyuria. That is the pyuria. We will see the muddy brown cast. If this keyword you can get in the case of. So this is the muddy brown cast. Somebody write already pericardial effusions. The muddy brown, this is the muddy brown cast. This is the muddy brown cast, or we will having the renal tubular cast. This is tubules, renal tubular cast will be there. The renal tubular cast will be there. So we have the muddy brown cast or the renal tubular cast. That is the important or the characteristics findings of the acute interstitial nephritis. See, this is the highly, if you are getting the in the questions muddy brown cast or the renal tubular cast, so that is the highly suggestive of the acute tubular nephrosis. That is the highly suggestive of acute tubular nephrosis. The acute tubular nephrosis, or we can say acute tubular nephrosis, or we same conditions we can call it as the acute interstitial nephritis. Acute tubular nephrosis or acute interstitial nephritis. Okay, so remember in highly suggestive in case of in patients with the acute rheumatic fever. In the patients with the acute rheumatic fever, this is the highly suggestive of acute tubular necrosis. Okay, so this is what we have the about the interstitial nephritis. I'm showing it again. Acute interstitial nephritis, the type 4 hypersensitivity. There is a T cell CD4 positive in interstitiums. There is a reversible cause of acute kidney injury, often due to immunologically induced hypersensitivity to the drugs. There is a no edema, no hypertension, usually asymptomatic. Rashes will be most common, extrarenal symptoms will be there, or eosinophilia will be there. Maculopapular rash will be there. Renal impairment, after drug has been started, we will get the renal impairment. Lab findings, we will see the proteinuria, we will see the WBC in urine, we see the hematuria, we will see the oliguria, we will see the CD4 count. Renal failure, pyuria, they are the rare findings, but they both are the rare findings. These things, we have the muddy brown cast or the renal tubular cast, the highly suggestive of the acute tubular nephrosis or the acute tubular nephrosis or the AIN, acute tubular nephrosis or the AIN in acute rheumatic fever. See the question now. There is a acute respiratory viral infections, complaints of pain in the lumbar regions, nausea, dysuria, oliguria. So there is a dysuria and we can see there is a oliguria. Along with that also you can see, remember why there is a pain in the lumbar region, where the kidney is present. Kidney is present retrograde. Okay, kidney is present on the retrospectively on the in the lumbar part. So that's why the there will be the pain will be referred to the lumbar regions. That will be the pain in the lumbar regions. There will be the hematuria. Yes, there can be the hematuria possible. The specific gravity, the creatinine levels. So whenever you will see any problem in the kidney or any kidney injury or renal injury is there, the creatinine level पहले आएगा. The creatinine level firstly will increase. The creatinine level will increase. The creatinine level, any kidney injury or renal injury, the creatinine level will be increases. The potassium level, this is what 3.3 to 5.5. Normal level is 3.3 to 5.5 millimole per liter. So make the diagnosis. So what is this condition? Acute interstitial nephritis. Okay. So this thing you need to remember. If you are getting the pain in the lumbar regions, along with that there can be the respiratory viral infection history, and oliguria is there, hematuria is there. All these findings can be possible that we studied. If they are in the question, they will be muddy brown cast, renal tubular cast. That is the more than enough to diagnose these conditions. Okay, along with the eosinophilia, and you will get the maculopapular rash as well. There is a no edema, no hypertensions will be there in these conditions. Remember, in case of nephrotic or the nephritic syndrome or glomerulonephritis, you can see the hypertensions, you can see the edema. So here, that's why the answer cannot be the acute glomerulonephritis. Acute renal failure, it is the different things. Acute cystitis, there is nothing about the acute cystitis. They are not talking about the urinary bladder. There is a pain in the lumbar regions. That's why we can call this condition as the cystitis is the inflammation of urinary bladder. Acute renal colic, the colic that can be the possible, but they didn't give anything related to the there any stone history or anything will be there. So that's why it will not be possible. See, acute and also remember the acute interstitial nephritis, it can complicate and it can complicate into the acute renal failures. So that will be having the other symptoms you will see in that conditions as well. They will give you something history about the acute renal failure, so they can give you in the questions that the patient is going under the hemodialysis or the dialysis is there, so or the creatinine ratio will be more, very much more. Glomerulonephritis, I just told you the glomerulonephritis, there can be the specific gravity. Specific gravity is like normals, that I need to again check. So I think it's like around this term only, the specific gravity is that. Yeah, it's 1.005 to 1.003. Okay, that is the normal. They didn't give these things, but it is a one. It's like little less, 1005 to 1030. Okay, So remember this thing. Creatinine level, the normal result will be the 0.7 to 1.3 milligram per deciliter. Okay, in the liter it will becomes the 61.9 to 61.9 to 114 point, because these all these values they will give you, so you don't need to remember. Yes, I think 0.18. Okay, I will share you this these things after the all these normal values. Normal values sometimes they will give you like after the when you are the Croc 2 exam. So in the end they will give you all these value. Okay, so you don't no need to remember these things for now. हाँ अभी बता रहा हूँ भाई. See, in options, glomerulonephritis, I just studied, just told you, see, there is a no edema and hypertensions, we discussed, there is a no edema, no hypertensions, and this patient is usually asymptomatic. But in the, remember, just for today, we only discussed that there the patient is having the proteinuria, there is a edema in the nephrotic syndromes. See, in the nephritic syndrome, we studied that the patient is having the hypertension, and also we studied there is a hypoalbuminemia, edema is there. So that's why this in that acute glomerulonephritis there is something that related to the nephrotic, there is a high proteinuria will be there and everything. So there can be the edema, hypertension, all these symptoms you will get. And acute renal failure, it's not possible, because in acute renal failure also they will give you this is not the complication. It can be the complicated to form the acute renal failure, but in acute renal failure there will be the there is a retentions like of urea, the creatinine level will be much high, and there is along with that there is a retention of the urea and nitrogenous waste. And also they will give you some history about like the patient is undergoing the dialysis. The patient have started with the acute interstitial nephritis, and along with that the patients will having the now it's going under the hemodialysis. The some kind of history they will give you about the renal failure, and then it will become the diagnosis as the acute renal failure. Okay. Okay. Now let's see the next questions. A neonate was born from the first gestation on the term. The jaundice was revealed on the second day of life. Then it becomes the more acute, the anemia, vomiting, hepatomegaly. I think we will do it tomorrow, these questions, because jaundice. Their very last question about jaundice. So do you want the jaundice discussions, complete discussions about jaundice, because that we already discussed in the during our Croc 1 times, or you can just revise that thing only. Okay, so let's continue with this only, because these questions that not just I think very last questions. If further questions will comes, definitely we will discuss the whole jaundice about the all those the Crigler-Najjar syndromes and everything we will discuss. Now, so let's do this question. Neonate was born from the first gestation on term. The jaundice was revealed on the second day of life. Then it becomes more acute. The anemia, vomiting, or hepatomegaly were observed. Indirect bilirubin level was 275. Direct bilirubin is 5. See, the indirect bilirubin is much more than the direct bilirubin. Hemoglobin is less. Mother blood group is O1 Rh positive. Child blood group is R. So both are Rh positive. Both are Rh positives. So this cannot be possible. Okay. Whenever the Rh incompatibility, if mother is Rh negative, if mother is Rh negative and the children, if the son or the children is Rh positive, or we can having the, if the child is Rh positive or the like father is Rh positive, from the father one positive gene will go to the children and it become the Rh positives. So in that case the Rh incompatibility is possible. Here the condition is that a blood group is given O and the children's blood group is given A. I hope you all know. If we have the four type of the blood group A, B. We have the four type of the blood group A, B, AB and O. Now O is what? Universal donor, and AB is what? Universal recipient. So A, what we have, they have the A antigens. They have the A antigen. They will having the A antigens. They having the A antigens. So we can A antigens, and so we will having the antibody. They have the antibody against the antibody against B. In B we have the B antigens. We have the B antigen, and they have the antibody against A. They have the antibody against A, because antibody against B and AB, again the same thing. The antibody against A and AB as well, because they have the antibody present, the antibody A antibody present, that is again that will be work against the A as well as AB as well, because in AB we have the both antigens, A antigen as well as B antigens. So they have the both antigens, that is A antigens and the B antigens. Both antigens, that is A and B are both present, and they don't have antigen. No antigen is there. No antigen is there means they have the all antibody. They have A antibody as well. They have the A antibody as well as B antibody. They have the both antibody will be there. There will be having no antibody. They will having the no antibody. Those who don't have antibody are the antibody are saver, that protector of any thing. So if they no antibody, everyone can give her. Everyone can give him. So that is, if there is a no antigens, if there is a no antigens, he will not give to, he can give to anybody, but he will not take to anybody. He will just take with the O, because O don't have antigens. So O can give to the O only. So if you are seeing that this patient, I hope this is this you understand everything. If no, then just write me no, or I will repeat it. Need repetitions or it's okay? Just give me thumbs up. Okay. Okay. See, now in this question we can see that there is a mother blood group is O and Rh positive. The child blood group is A. So mother blood group is what? O blood group. So O blood group we can say, or we can say mother is what? Mother is what? O. So O means we have the IO and IO. So they have the O blood group, means no antigen is there. And what was the children's blood group? The child blood group is A. The child blood group is A. So that is IA. Okay. So if no antigen is there, what will be there? The child having the antibody. Which antibody? They have the antibody against the B and AB, and they have antibody against the A and B. So this is they have the antibody against the A and B. They have antibody against the both. So that's why it will create a problem, and they will having the ABO incompatibility. I hope you understand this. See, mother having the M for mother. Mother is having the A antibody. Mother is having the A antibody, and this antibody will work against the children's A antigen. Children A antigens. It will work against the A antigens, and that will lead to the ABO incompatibility. I hope this is clear. Okay, that's why we have the hemolytic disease of the neonates, that is ABO incompatibility. And which type? Icteric. Icteric means jaundice will be there. Why the jaundice is there? Because we can see there is a indirect bilirubin is there. So which type of the jaundice? The indirect jaundice will be there. Okay, or we can say pre-hepatic jaundice will be there. We can see the pre-hepatic jaundice in this case. So because indirect bilirubin is 270, how I will remember that which the indirect bilirubin is more? You see the value, indirect bilirubin is 275 and direct bilirubin is just 5. So that's why if you are getting the similar things, means you are both are in equal amount. But if you are getting if you are getting the direct bilirubin is 275, indirect bilirubin is 5, it means that direct bilirubin was more. But here we can see the indirect bilirubin is much more than the direct. That is why we call this is the icteric type, and icteric type means we have the icteric means jaundice. I hope this is clear. This is the same questions. The blood group of the mother is O and the children blood group is A. So this is just correct this. This is not RH. This is ABO. This is not RH. This is A. This is the correction here. This is not RH. This is the ABO incompatibility icteric type. Okay. See the questions. Let's do the question so we get the little relief. Suffering from the acute pneumonia, question number 14, which was complicated by there is a patient having the acute pneumonia, complicated by the cardiovascular insufficiency and the respiratory failure of the second degree. The accompanying diagnosis is malnutrition of the second degree. Choose the best variant of the therapy. See, the patient, the 7-month-old infant. This patient is having this baby is having the acute pneumonia. Now you are seeing that this is complicating, means it's going towards the severe pneumonia. In the severe pneumonia, what we say, what the best variant we will give? We will give the amoxicillin or what we can give? Oxacillins. Along with that, we can give the aminoglycosides. AMG is aminoglycosides like gentamicin, amikacin. This is again the aminoglycosides. These are the drugs, gentamicin, amikacins we can give. So here we have the Ampiox. I told this is the another name of oxacillin, Ampiox. So we will give these conditions in the case of the pediatrics pneumonia. Okay, so remember these things. Okay, then okay, you want to continue or you want break or you want to finish today? It's on depend on you. If you want, then continue. Then we will do the 2 questions. Finish. Everyone, please. Okay. Finish for today. Okay, I think this is enough. See, I told you this week we are going very slow, but for next week I need to take the longer classes, है ना? So that we can complete the syllabus on the time as well. This is slow. I mean, like we will take the timings, more timing in the terms of. Sir, please discuss more MCQ and optional explanations in the. हाँ भाई देखो, अभी तुम्हें लग रहा ना वी आर कि बहुत कम क्वेश्चंस हुए हैं, है ना, 5 या 10 6 क्वेश्चन हुए हैं. सो जितने भी है ना सारी चीजें कंप्लीट होंगी. देख भाई, मैं अगर मैक्रोपिन डिस्कस करूंगा ना तो मैक्रोपिन तो तेरे कहीं काम का ही नहीं है. सो व्हाट मैक्रोपिन डिस्कस करके मैं करूं भी क्या? दिस टाइप जो भी वट एवर द ऑप्शंस आर इम्पोर्टेंट. See, I know like some questions if I am getting like RH incompatibility, hepatitis, physiological jaundice due to conjugation disorder, तो ये सब चीजें ना रिपीट होंगी और whenever the repeating तो सारी चीजें कनेक्ट होंगी. बट जो चीजें काम की है ही नहीं, what when those things that are not so important. Okay, just a second. Those who want to we are finishing it now, and those who want to leave, you can leave and take the rest, and please revise before you sleep. And those who want to stay, just stay. We will give me just 2 minutes and we will little talk.